Hello, everybody. Happy Wednesday. I'm so happy to be here with Dr. Danzer, my partner. I'm Carolyn Alexander. I hope everybody's having a wonderful day. Today, we're going to talk a little bit about navigating infertility and building a supportive network. And I know here at Southern California Reproductive Center, we're all here for you. We put a lot of effort and give compassionate, individualized care. And I'll let Dr. Danzer introduce himself too.
Thanks, Carolyn. Yeah, this is an important topic, building a supportive network, which includes your healthcare team and your family, friends. The treatment of infertility is short for some and is a real trek for others. And it's important that you have a supportive team. The stress involved in dealing with infertility is significant for everyone. And having supports is really important in terms of better success. We know that the stress does not help anybody's physiology. And anything that you and your team can do to lessen that stress helps you respond better to your treatments.
Definitely. So I'll just talk a little bit about myself too, and Dr. Danzer will as well. I was born and raised in LA. I went to UCLA for undergrad and medical school, and my research passion has been on polycystic ovary syndrome as well as recurrent pregnancy loss and fertility preservation. I trained on the East Coast in Baltimore at Johns Hopkins and then did fellowship there. And I worked at Cedars-Sinai for almost a decade, and I've been here a decade. Actually, it's 10 years, I think literally to yesterday. But it's been an honor to take care of patients. I know how strong everybody has to be. I also an older mom, so I understand how it feels. So I think, it's really important to recognize how important it is to have a supportive system and just understand what you're going to be going through and the steps, and we're here to help along the way. Next slide.
So SCRC was founded about 25 years ago as co-founder. Dr. Alexander has been with us for 10 years plus. Trained at USC and UCLA and Cedars-Sinai, but primarily focus has been on the infertility treatment at SCRC for the past 20 years plus. My grandmother was a midwife in rural Montana back in the early 1900s, and can only imagine the kind of treatment they had available for fertility compared to now. So just 2 generations, how the world has changed for fertility for women. So as we'll go through later on, you begin to get a sense of the science and the sophistication of the diagnostic treatments diagnosis instruments and treatments that we have. So SCRC is, like I said, been here for 25 years plus. I think we have a state-of-the-art embryology lab, and I think we have been known for the quality of our lab for the entire time we've been here. We've spent a lot of effort and finances into creating one of the finest IVF laboratories in Southern California in the US. We measure that by the progression of embryos to what we call the blastocyst or 100-cell stage. I think that's a good marker for the quality of any embryology lab, and then certainly the pregnancy rates that go along with that. We have a surgery center for hysteroscopy and all the things that we need to do to prepare anatomically for transferring embryos. We have a main location here in Beverly Hills, but also satellite offices in Pasadena, and also Santa Barbara that has a embryology laboratory. So we talked about what goes on to really a high quality laboratory, which is really the centerpiece of a fertility clinic. It's experienced embryologists. We have almost a dozen embryologists. We're staffed for 7 days a week. We don't break for the weekend. We have enough embryologists so that we can double witness every time an egg is taken, when it's fertilized, when it's thawed. There are 2 sets of eyes on identifying and verifying that that's the proper embryo. We talked about blastocyst biopsy again. Growing the embryo in the laboratory is very important because you need to grow the embryo for 5 or 6 days before you can genetically test an embryo. And the greater number of embryos you have to genetically test, the greater number that you'll have for transfer. And that relates directly to, again, the pregnancy rates. Our laboratory, one of the few laboratories here in Southern California that has what they call an embryoscope. And it's a newer technology where they're doing time-lapse imaging for embryos. And once they're fertilized, they grow 2, 4, 8 cells. Some embryo goes 1 cell to 3 cell, 2 cell to 5 cells, or sometimes drops back to 2 cells. If an embryo is not growing symmetrically in the very early, it may indicate there are some genetic issues with that embryo, that it may not have the greatest potential for pregnancy. So when you get a group of embryos that are genetically tested and they're normal, then we go back and we can rank those embryos. The ones that have divided in a non-symmetric way, they're kind of at the bottom of the list because they have a lower pregnancy rate. So it enabled us to transfer the embryo that has the greatest potential first. And again, that creates the best pregnancy rates in the first or second embryo transfer. And here is certified director of the laboratory and the physicians, and we certainly collaborate with all the accredited laboratory services in the U.S. So today's discussion, we come back, we always hate to talk about it first, but age factor is the most important determinant of success and how we treat patients. Talk about mental health during the holidays, which is a difficult time when you're struggling with fertility. You're getting together with family and they've got kids and they got pregnant the first month or two they tried, and it's painful. You know, how do you deal with the stress that goes along with that? And then we'll talk about fertility treatment options and a little bit about Meet Our Team and special offers. And then we'll have question and answer at the end. I know that a lot of you have come today because you have some questions about your fertility or starting treatments, or you've had treatments and where to go next. So here's Carolyn, do you want to start, or?
Oh, I wasn't sure if this is, but either way,
Okay.
yeah, I can, I think, start too, if you'd like. Like Dr. Danzer said, age is an important factor, and he sees a lot of patients that he's helped over the years too that are older, and we always both say there's a golden egg to help us stay positive and motivated as we are trying to get pregnant. But when we're under age 35, if you've been trying for a year with regular periods and also having unprotected intercourse, then that's considered infertility. When we're over 35, time is not as much on our side due to the risk of chromosomal changes in the eggs as we get over 35. So traditionally, we say try for 6 months of regular intercourse and having regular periods. And then if it's not happening, consider getting a detailed evaluation at that point. Next slide. And as we were talking, around age 35, there's a change in the chromosomes. The mitotic spindle starts to get sticky, and as the egg fertilizes with sperm, there may be an extra component of aneuploidy, which could be an extra chromosome or a missing chromosome. And so genetically normal eggs starts to go down as time goes by. It doesn't mean it's impossible. It just means that it's a bit harder for us to recruit the best egg to come and help us get you pregnant. And so age is a factor, but it's important to stay as healthy as you possibly can. And we do everything with all the medications that are available to help you through the process. Next step. In terms of natural ovulation, when we were in our mom's abdomen, when she was pregnant with us, there was actually the highest number of eggs in the ovaries. And then as we were born and as puberty hit, the egg supply started to go down. The eggs are in the cortex, which is the outer rim of the ovary. And the picture on the left are each circle has one potential egg. It's smaller than a grain of salt. And as time goes by, there's less and less opportunity for those eggs to ovulate. And so in our fertile window, we have over our reproductive age and time, 400 to 500 oocytes or eggs until we hit the M word or menopause, which can be at a younger age if we are using a lot of tobacco or have a family history of early menopause. So it's important to talk about that with your doctor too, and to avoid toxins as much as you can. Next slide. Oh, mental health. I'll let you do this, Dr. Danzer.
Okay.
Yeah.
So, it's estimated that half the women and a third of men have symptoms of clinical depression while going through fertility treatments. Many times, this is the first confrontation of an obstacle, a huge obstacle in a couple's life, or a single person that's going through fertility treatments when they haven't been able to get control of their life. Loss of control is very stressful, not knowing the future. And how do you get a plan to move through the treatments and minimize the amount of stress and to your physiology? They say 76% of women and 60% of men have anxiety going through it. And the anxiety is not knowing the future, not knowing if it's going to be successful, anxiety over the cost of it, if there's a lot of insurance coverage or non-insurance coverage, fertility treatments today. Here in California, they're supposedly going to have insurance coverage with IVF in the future. What that's going to look like in terms of reimbursement and everything else is yet to be worked out. But I think that'll take some of the pressure off some of the women and couples going through it, because the financial stress is huge for everyone. 3/4 of the people going through infertility treatment report feeling depressed or anxious during the holiday season. And we talked about that. Holiday time is the time where families get together, and clearly older sisters, younger brothers, they've had their family, got pregnant easily, and here you've been struggling for years. And the families say, well, when are you going to start, or why aren't you pregnant? And it's hard to put out the information about what you're going through. It's hard to talk to people about the failures of the treatment. Unfortunately, family members and some friends are not asking the right questions about how can I help? How can I be supportive? Do you want to talk about what you're going through? Or, some people don't want to put that out. They want their privacy. Families tend to get a little bit intrusive, parents. And that's difficult. That's something that every couple or individual has to work through on their own. But I think it's the most important thing is being able to open a dialogue with someone that you trust within the family. Obviously there's people you don't want to tell things about personally, but developing, again, a group that can be supportive of you while you go through the treatment, I think is beneficial. Stress does not help anyone's physiology, and everything that you can do to manage the stress and the anxiety or the depression can help you get through the process more easily, and I think has a lot to do with success in the end. Go next slide. So they talk, what sort of feelings come up during the holidays? Being alone and the grief, or a lot of times it's the feelings of guilt, that what are we not doing that we should be doing? Am I not, people ask, am I not eating well enough? I'm not exercising. I'm not taking care of myself. And it's true, a lot of people don't take care of themselves. They get caught up in all they have to do with their life and work. Um, you've got to set a time for yourself to really look at what serves you in terms of what you need, and being able to tell those around you in your support group what you think you need at the time. And to be able to, again, have someone that you can trust, that you can ask for the things that you need. But it takes a little while to uh, sit and have some quiet and say, what do I really need to get through this really stressful part of my life? We talked about uncomfortable questions from family and friends. You've got to get a place in your mind where you know what you're going to say to Uncle Jim or to your mom in terms of what you're doing, or yeah, we're in treatment, we're doing well, but that's really, I think, all I can say about it now, and that's fine. You have to set your limits in terms of when they ask what you're willing to expose or not is important. Receiving holiday cards, from all your friends that got the kids and the dog, and you feel like you're alone in some ways. So that's what's important with having a support structure. You're not alone. They talk about surrounding by children and other family events. You should join in with that. Don't feel that you can't be part of a family just because you're struggling to create your own family. Suppressing the feelings of sadness to prevent the kind of awkwardness during these times. Suppressing it, but acknowledging the fact that, yeah, it's sad. I'm it's painful. I'm struggling, and that's okay. Everybody goes through that at difficult times in their life, but it doesn't mean that we can't move forward with that. And this can be a great time of growth, a time of a lot of stress in your life. Kind of teaches you things about yourself, and again, helps you develop a pathway to deal with that stress. I'm a great advocate of mindfulness. I think there's some great mindfulness apps. Again, giving you time to listen to yourself uh, is probably one of the most important things you can do in terms of getting through the stressful holidays. Go take it, go into the holiday, taking a break from social media. Yeah, I think we all need to do that. Um, and yeah, holiday traditions, uh, you still ought to do it. And as a couple, when you're starting to get pregnant, do we participate in these kind of family issues, get a tree, or participate in religious events? And again, if you don't feel comfortable, it's okay to say no to things that are not going to be helpful in your life at this point in time. You don't have to feel guilty about that. It's if you're not comfortable with it, it's okay to say no. And then again, we talked about sharing your feelings with your support team. Again, having someone that you trust in the team, that you can really tell them about your feelings. It's okay to have those feelings. Like I said, we talked about responses to uncomfortable conversations. Yeah, you sort of need to know what mom's going to ask, and what Aunt Sally is what she's going to say. And it's okay to say no. We're working on it. Hopefully we're going to be very successful in the near future, and then go to something else. But taking care of yourself during the time is important. And having some time by yourself to really see where you are and kind of listen to your feelings, and develop a plan how to get through the holidays. It's really important. We have a in-house acupuncturist. I think all the doctors here are feel that acupuncture can be worthwhile. Again, The philosophy of acupuncture is to get the body in harmony. And again, they're stimulating the nervous system. We know the nervous system is involved in almost all your bodily functions, whether it's your GI tract, your reproductive tract. You talk about balancing your hormones, relief of stress. There's some studies that have said increased pregnancy rates of 16%. It's difficult to do studies with acupuncture because it's hard to get a control group, but it's been here for 3,000 years, and I think it's been helpful for many, many of our patients.
Yeah, so I love acupuncture. It helped me as well. And I know Dr. Danzer's very much into mindfulness and exercising a lot too. You inspire me as well when I see your Saturday morning workouts. So I think nutrition's really important. People always ask us, how long do I have to be super healthy before I freeze my eggs? Well, the traditional kind of rule of thumb is around 90 days ahead and about 72 days ahead for sperm. But generally speaking, having a well-balanced diet is important. If you have a cheat day here or there, that's okay. Eating a Mediterranean type of diet, lots of fruits and vegetables, avoiding processed foods, as well as fried foods and inflammatory foods. And then meditation or journaling or mindfulness too is very important to recognize. Lately, I've been telling patients, do you have any specific fears or concerns? And sometimes just talking it out, you sort of break the cycle of the fear of and sometimes patients are really, really worried that something will happen, but the likelihood is very low. And so in clinical practice, we don't see it often. And so when we talk about it, it's good to air out the thoughts. Next slide. In terms of nutrition, like we were both saying, Mediterranean type of diet, lots of whole grains, vegetables, legumes, fruits, nuts, and seeds. Brazil nuts have a lot of selenium. Selenium may improve thyroid function for people who may have a borderline thyroid issue. Pumpkin seeds have magnesium if someone's having a lot of constipation. Folic acid's been supplemented in a lot of grains, but it's in asparagus, dark leafy green vegetables. B12 is very important, as well as omega-3 fatty acids, which is in salmon and fish and chia seeds, flax seeds, walnuts. Sperm also can be improved with eating more walnuts and fish, but not farm-raised fish if possible. Sometimes it's hard to differentiate and you don't want to get too stressed out about it, but sometimes there can be additives in the food and some of the farm-raised fish. Next slide. It's important to avoid toxins. Heavy alcohol use is not as optimal for egg or sperm quality. And so having more than 4 drinks per week during IVF had a lower live birth rate and a 48% higher risk of failed fertilization. And so it's important to really try to limit alcohol. We typically tell patients to avoid too much hard alcohol as well. It can impact quality. Cannabis and CBD oil is a common question that we get asked often, and it may be associated with fewer eggs as well as impact the morphology of sperm. And so it's good to limit. Sometimes we can't really say to cold turkey if someone's having daily use because there can be some ramifications to that. So usually we say go down to about half of what you're doing and then a week or two later go down again by half. So especially if someone's having daily use, but it's good to remember that some components of especially smoked marijuana can have other minerals and nutrients that are not good for us as people. And so you could use other forms of ways to relax or other tricks up our sleeve to help if there's a specific reason you're using it for sleep. And tobacco is important because it can reduce AMH or anti-Müllerian hormone level. It can also reduce the antral follicle count and it reduce our pregnancy rate. And so I always think, oh, we really want to prepare for pregnancy like you're preparing for anything you're doing for work or responsibilities you may have. So avoiding tobacco and these toxins may be optimal for your body, especially with men too. It can impact sperm motility. And when we see patients reduce the tobacco use, we see the sperm motility bounce back. So that's pretty impressive. Next slide. In terms of the patient evaluation, we talk about egg supply, egg quality, the fallopian tubes, the uterine health, as well as sperm quality. And that can be evaluated with a semen analysis or a sperm DNA fragmentation test. We talk about the physical exam because we do find it very important to make sure to be up to date with your pap smear. We've caught patients right before embryo transfer have an abnormal pap and need further testing on the cervix. That would be very important to know before we're pregnant. And then the diagnostic testing, we're going to go over that as well. Next slide. The HSG is the hysterosalpingogram. It's done day 6 to 10 of your menstrual cycle. It's a little thin catheter that goes through the cervix and pushes dye or fluid through the fallopian tubes to take an image of the fallopian tubes as well as the shape of the uterus, which should be about the shape of a triangle. And so this is an image of the fallopian tubes on each side of the triangle, and the balloon is impacting the view right here. So with the balloon inflated, it's harder to see the lower uterine segment in this specific image. But the HSG is an important test. There are also newer ways to do it without X-ray as well that are available for fallopian tube determination. Next slide. The hysterosonogram, or HSS, is saline that's injected through the uterus to evaluate for uterine polyps, submucosal fibroids, any synechia or scar tissue. Sometimes we can see an isthmocele, which is an outpouching where your C-section scar might have been, and it's important to recognize that that may be a weak point. So in a subsequent pregnancy, we may have to talk to your doctor about options before an embryo transfer. In addition, with the hysterosonogram, when the fluid's going in, it gives us a sense too of how the catheter may go in for an embryo transfer and any obstacles or problems that may impact the success of an embryo transfer or pregnancy in general. Next slide. And female testing, so I mentioned AMH, anti-Müllerian hormone level. It's produced by the granulosa cells. It's an important level, but it's not a perfect test. My own was low, and so it doesn't always mean it'll be impossible if it's low. But when it is low, it means there's less egg supply there. Sometimes it can be falsely suppressed by birth control pills, especially if we've been on the pill for a long time. There are newer scientific articles saying if our vitamin D level is very low, below 10, the AMH may not be as reliable in that assay from the technical side of the blood test result. But when we're age 26 to 29, a normal AMH is 1.96 to 5.8. When we're age 30 to 35, normal is 1.4 to 4.2. When we're 36 to 39, normal is 0.84 to 2.8. When we're 40 to 44, normal is 0.42 to 1.4. And over age 44, it tends to go down. But sometimes we'll see patients that have an AMH that's super duper good and they're over 40 or over 44. And that's always impressive in terms of egg supply. But as Dr. Danzer mentioned, and the genetics slide shows, as time goes by, the genetics of those eggs starts to change, and there's a higher risk of chromosomal abnormalities in those eggs. In addition, we check FSH as well as estradiol and LH on the 3rd day of your period. Sometimes we do it on the 2nd, 3rd, or 4th day of your period, depending on which day. And that FSH is from your pituitary gland, which is your master control gland from your brain. And we want the FSH hopefully below 10. Typically, we traditionally see it below 15. Sometimes if it's higher, it can be a reflection of egg quality issues as well as age. And it can start to go higher if we've been exposed to any prior chemo or radiation or any medications that impact our ovarian reserve as well. Stress can sometimes play a role, so we don't always trust one level. We have to reevaluate it. And we use it in conjunction with the follicle count, which is the ultrasound. Each little black circle has one potential egg, and we want to see 5 to 10 on each ovary. And so it's important to do the antral follicle count around the first week of your period so we can get a sense on the ovarian reserve. Next slide. Do you want to talk about supplements or?
Yeah, we have a lot of questions about diet and supplements. Prenatal vitamins, I think, are kind of the most important. There's a good amount of research showing what you need in terms of prenatal vitamins for pregnancy, and they have additional folate. There are a lot of prescription prenatal vitamins. I don't know if they're any better than the over-the-counter. The cost is different, but I think as long as you have good nutrition, vitamins, I don't think you need to add any other supplements. A lot of people take extra D, and I think that's like to have that high range of normal. So we always check your vitamin D level and add supplement if necessary.
If you're,
CoQ10 is go ahead.
oh, no, I didn't have your, sorry.
Okay. So CoQ10 is a supplement associated with a number of eggs at retrieval in some studies. And again, it's doesn't have any side effects. It's 200 milligrams 3 times a day, and it's over the counter. And I think many of our patients take CoQ10. May be helpful for men also. I don't think there's any magic supplement. I know there's a lot of people that do herbal supplements. I don't think there's any problem with most of those. I just wish, the FDA would open some studies to look at supplements to see really their benefit. But until we have that information, it's really hard to know how beneficial they are. But I don't think they're really harmful most of the time.
If you're on metformin for polycystic ovary syndrome, B12 deficiency can rise. So it's good to think about that as well, too. Next slide, yeah. In
Male
terms,
testing, early on, we like to have the partner come in. In a semen analysis, they look at volume, they look at concentration. You want to have more than 20 million sperm. The average is probably about 40 or 50 million for most men, as long as they're healthy. Probably the most important thing is how they swim, what they call motility. And you want to have over 50% that are really strong swimmers, because it's only the strong swimming sperm that are going to be able to find the egg and then burrow through the outer coating. Morphology of the shape of the sperm has been a kind of an issue over the years, but 90% of the sperm are pinheads, double heads, giant heads. But if you've got 20 million sperm that have good motility, the morphology really isn't so much of an issue. However, when you have a lower sperm count and lower motility, then morphology can be a part of that there's a struggle, the development and the maturation and the quality of the sperm. Studies say maybe 25% of fertility is due with male factor. Again, that's why we always try to get the semen analysis early. For men that have lower sperm counts, so sometimes you look at the DNA fragmentation, which may affect, again, the quality of the sperm and the ability to fertilize an egg and produce a good pregnancy. But the initial sperm count is the very first test for the man. But luckily, healthy men, usually 90% are going to have a pretty decent sperm count. Male supplements, Proxseed, which is L-carnitine and some antioxidants, is shown to be helpful to improve motility for some men. Again, CoQ10 we talked about may help sperm quality. And again, vitamin D is something we look at also. But again, we recommend a good vitamin for men, exercise 3 to 5 times a week. So nutrition and exercise, and also stress reduction. A lot of guys are working, 40, 50 hours a week. That takes its toll on all your organ systems, and it may have effect on sperm motility. So trying to have some time for recreation is important in terms of one's overall health. Here's a slide on what they call IUI. Carolyn, do you want to talk about IUIs?
Sure. Yeah. So IUI gives an opportunity for sperm to be placed in the uterus to the top right when ovulation's occurring. And in some cases, it helps us bypass the cervix, where sometimes the mucus could be a little tricky for the sperm to swim through, or if the sperm motility's a little low, then actually getting the best players to the top can be better. And in some patients, we use donor sperm in some circumstances, if men have azoospermia and the urologist isn't able to get sperm, or if patients are using anonymous or directed donor sperm as well. During the process, we bring you in on day 2, 3, or 4 of your cycle to check your ovarian reserve levels to determine if you need superovulation or a medication that could help you ovulate better, called Clomid or Letrozole. They've been around for years. They do have a small risk of twins, and if we do see more than 2 or 3 follicles, we'll have a discussion about the concern or risk for multiple pregnancy, and that doesn't happen very frequently. In addition, we do an ultrasound day 6 to 10 to determine if you may benefit from a trigger shot, which is called HCG. It's a subcutaneous injection that causes the LH surge. It mimics the alpha subunit of LH, or luteinizing hormone, and that can cause the egg to expulse from the follicle right when we're placing the sperm inside for the IUI. You're here for some time because it takes us about an hour to process the sperm. And then the procedure is about 10 minutes and you lay here for 15 to 20 minutes, but you can go to work afterwards. You don't have to go home and lay in bed or put your legs up, because once the sperm is placed inside, it goes to the fallopian tubes promptly and it stays in there. It won't come out. Then sometimes we'll give luteal phase support with progesterone to support the early embryo trying to develop, and a pregnancy test is 2 weeks after the IUI. And that's the process of the IUI. Typically, prior to this, we would have talked about the fallopian tube test, and as Dr. Danzer mentioned, the semen analysis, and do some pre-testing and genetic carrier screening for cystic fibrosis, which is 1 in 32 Caucasians carry cystic fibrosis. We check for sickle cell trait, thalassemia, Gaucher's. And so all the genetic testing, because we don't want both partners or both the egg and sperm to carry autosomal recessive or an autosomal dominant disorder that can pass on to the next generation. So it's important to do some of those pre-tests. Next slide. In terms of the egg retrieval timeline, the process does start with a baseline ultrasound to determine if that month is a good opportunity with a good follicle count, FSH level, estradiol, LH, and to think through the month prior, like Dr. Danzer mentioned, vitamins, nutrition, meditation, all the options to improve egg quality and sperm quality. And then during the ovarian stimulation, you may take 2 to 4 injections. Those have been around since the 70s. They're called follicle stimulating hormone, luteinizing hormone, sometimes human growth hormone, as well as either a GnRH agonist or antagonist. There's 5 visits. We open at 6:30 in the morning, so some of our patients get in and get out. They can make it to work on time. And we review the images as if we were right there. And that's a ultrasound to determine how the follicles are growing, as well as a blood test to evaluate and protect you from ovarian hyperstimulation syndrome, as well as to see how the follicles are developing, because over that 10 to 12 days, we are hoping the follicles grow from 5 to 8 millimeters up to 18 to 22 millimeters. So we're monitoring you very closely. Then there's a trigger shot day that can be HCG or a Lupron trigger or a combination. And then about 36 hours later is the egg retrieval, which is a transvaginal procedure under anesthesia. It's a 15 to 20-minute procedure, but for about 7 days after, you're bloated, headache, mood swings, breast tenderness. Some people call us with constipation, and your period will come about 10 to 14 days later, and it can be quite heavy and uncomfortable, that period, because you ovulated more than the one egg for that month. Next slide. This is an image of how we do the vaginal ultrasound. It's a thin needle through the back wall of the vagina into the ovary, and we carefully get the eggs out. The egg retrieval is done in our facility on the 5th floor, and our lab is fantastic, and the lab team is in the embryology lab, and they're taking the fluid and looking for the egg, and it's all done in a synchronized, timely fashion. Next slide. This is an image of the egg. It's about 100 microns, and the polar body is up at the 12 o'clock site. This is the ICSI pipelle with the sperm being placed at perpendicular to the polar body into the egg. They draw back a little bit of cytoplasm to make sure they're through the zona pellucida, and then they place the sperm through. The sperm has been immobilized, and they've used a high-power microscope to pick the best head, midpiece, and tail so that the sperm is placed into the egg. In addition, the egg can be fertilized with natural insemination, but in some cases, the outer rim of the egg is very firm and rigid and doesn't let sperm through, especially in patients who are struggling with infertility. And so ICSI is an opportunity to get the best quality sperm placed in. And it's a process that's part of the discussion with IVF too. Next slide. The embryo development is very important. So the fertilized egg gets 2 pronuclei, then it grows to 2 cells, 4 cells, 8 cells, 16 cells. This is over 7 days. And we're able to do pre-implantation genetic testing for aneuploidy screening or for genetic mutations. We take 3 to 4 cells from the outer rim or trophectoderm, and then the embryos flash frozen with vitrification, and those cells go to the genetics facility to look for 2 copies of all the chromosomes or a specific gene. In some cases, it can be the early Alzheimer gene, a specific gene that your family could carry, and we could determine which embryos affected with that specific gene, or a double copy from each parent of cystic fibrosis or Tay-Sachs or sickle cell specific genes. Next slide. The EmbryoScope technology gives us morphokinetic information. It's helpful in cases where we're trying to determine perhaps why a patient in a different cycle had embryo developmental issues. It also helps us understand which embryo may or may not be better to transfer, so they can provide us with which embryo is a little bit better than the other for implantation. And it's been interesting providing some information. I was just reading about spindle length at the time in the EmbryoScope data on the egg, and aneuploidy risk. So they're trying to use it to help guide us to understand chromosomes, but ultimately pre-implantation genetic testing is the way we determine genetic screening of embryos. Next slide. In terms of, Dr. Danzer, want to do the embryo transfer protocol?
So today there's been a shift in how we transfer embryos. One is what they call a program cycle, where you develop the lining of the uterus with estrogen, either orally or patches or injectable. It takes about 10 days to grow the lining of the uterus, ovulation being around day 12. So we know that once the lining of the uterus is about 8 to 10 millimeters, then it should be receptive for implantation. The other alternative today is natural cycles, where we just wait and monitor with ultrasound to see where the ovulation is. And then when progesterone is released after ovulation, and these embryos are grown for 5 days before they're frozen. So we transfer after 5 days of progesterone. The good thing about a natural cycle, you don't have to take any injectable progesterone. Pregnancy rates are the same. There's some studies that suggest that some of the risk of high blood pressure during pregnancy may be lower with natural cycles. And I think a lot of women are electing for the natural cycle today. But again, the pregnancy rates seem to be the same for both. But once the lining of the uterus is prepared, the embryo is just drawn up into a catheter, which passes through the cervix. It's very small. It's not felt at all. And you see a little drop of fluid come out the tip of the catheter that has the microscopic embryo. And embryos don't fall out once they're in the uterus. We have everybody go home and take it easy for 2 days, but after you go through all that, you deserve 2 days to rest. But embryos do not fall out. Tell everybody to get up and walk around every couple of hours, get up for their meals, take a shower, and have some treats for 10 days, waiting for the pregnancy test result, which is performed 10 days after the transfer. But this is easy. This takes like 5 minutes, and no anesthesia. Again, no one feels the catheter going through the cervix. Very simple procedure. Next slide. Yeah, recovery process. And again, with IVF, you have one follicle, your estrogen on average is 200 or 300. When you have 20 follicles, your estrogen is 2 or 3 or 4,000. And high estrogens sometimes causes some bloating for many, some breast tenderness, sometimes headaches. And then there are women, 15% of women kind of have these side effects. 15% of women say, I was talking to a woman today, I feel great. I haven't felt better in a long time. I've got a lot of energy. I'm sleeping well. But again, when estrogen levels get in that 10 times the usual, there's going to be some symptoms. But most of it subsides pretty quickly after the retrieval. The estrogen then drops, and the period comes 2 weeks after retrieval, because that's the day of ovulation. Next slide.
Exercise should be avoided for about 2 weeks after the egg retrieval. Again, we do it under anesthesia, so most of our patients report that they feel pretty comfortable during the process. When they wake up, there's cramps, and that week, again, there's, like Dr. Danzer mentioned, bloating, cramps, constipation. Light walking's encouraged, and some arm weights are okay, but no core, no squats. It's important to refrain from sexual activity because of the risk of infection as well. And egg freezing cycles can be completed in back-to-back months. We have found that the second opportunity, sometimes more follicles recruit from the medication sort of lingering in the system and improving recruitment for the next month. Some people need a break for a month too to recover emotionally from the process, and so they'll take a breather month. It depends on each specific person too. Next slide. Storing frozen eggs. So we're often asked, how long do the eggs last? We've had patients here have eggs from 14 years ago that produced healthy babies, and we feel so blessed with that information. But in general, they're vitrified or flash frozen, and they're placed in the freezer. We keep them here in our building, and they're stored with our embryology lab, checking all the temperatures and the liquid nitrogen and all the details. There's a lot of strict rules here that we follow, and the survival of the egg rate, every 6 months we do a detailed deep dive into our statistics, and it's been pretty impressively consistent at around 89%. People say, how come it can't be 100%? Well, some of the eggs are sensitive to the freeze thaw process, or sometimes those eggs may not have fertilized either. And part of the important thing to recognize is sperm is half the battle to get a good embryo. And so it does take about 70 days or more to improve sperm quality from lifestyle modifications and avoiding heat to the testicles. We're often asked about hot yoga and these cold plunges. I think everything in moderation is fine, but extremes of heat may not be ideal for the testicles. That's why they're outside of the body. But in general, everything in moderation is important to understand. And storing your frozen eggs, everyone says, how many eggs do I need to get a chance for a baby? It's been an interesting job, and I know Dr. Danzer has a lot of experience with this. I think it's interesting to think that on average, we do need around 15 or more eggs to get a chance for a pregnancy. But what's our embryology team lead, Robin, did a 5-year retrospective look, and at age 37, it took 17 to 25 eggs to get a chance for a pregnancy. But our average age of patients is 39. And so we do seem to have to encourage patients to have a lot more eggs. But an embryo is always going to be stronger than an egg. And so we have to take a step back sometimes if it's not feasible to get so many eggs for some of the patients with lower egg reserve, and ultimately focus on egg quality, not always quantity. But we want to try to help people have realistic expectations for the future as well. Next slide. And so it's important to understand we're here for you. We're here to help. I love what Dr. Danzer was saying. You were reminding me before I started having a family of how many people ask me, when are you going to have a kid? Why are you so focused on your career? So I know how those questions can kind of feel. I think understanding that the holidays always are open up conversations, but having tools up your sleeve of how you want to approach them is important. I think we have a lot of promotions here, and we're really just trying to help each person with their specific needs and help you along your journey. Dr. Danzer, any other thoughts?
I was just looking at the the fall freeze. It doesn't freeze here in Southern California, but we try to have these specials. It's around the time of the holidays, so people want to freeze their eggs or make embryos before the end of the year. It feels like kind of a rush, and that's why we offer it. I think it's important, for all of you listening this afternoon to don't be afraid to get started with testing and treatment. Today, with our current day technology, success rates are very high, and that's important to know going into the holidays. Being hopeful.
Paul.
I guess we have a chance for questions now.
Yeah. I know I saw one question about the genetic testing on embryos. So there is a pendulum that has swung in terms of embryo testing for taking those fused cells off the trophectoderm. It's not a perfect test, but it does provide information. And there's been a little bit of more information about mosaic embryos, and Dr. Danzer was our leader in placing a mosaic embryo and healthy baby. And so I think it's really beautiful when I think about it in terms of embryo testing and the opportunities to think about the pros and cons in any specific scenario. So, and we have a genetic counselor, Caroline and Pamela, who sit with us, and they're always talking about articles and hot topics and stuff like that. So they're part of our wonderful team here. And so we put a lot of thought into making sure we have a multidisciplinary approach to that. Do you see the other questions, Dr. Danzer? I can see. Oh, is it under here? Let's see. If anybody has any questions, they can place them in the chat if you'd like. And we're happy to think things through, or feel free to see us in a consultation as well if you'd like.
And again, I know many of the on the conference today, you may have had some fertility treatment and want to have a second opinion, which is easy to do. You know, it's phone, we do Zoom, we do in person. It's important to have a plan, and again, for the holidays, having a plan whether you're going to start with testing or whether you start with treatment. That would what I would wish for you is to have a plan for the holidays, so it'd make it easier for you.
Thank you, everybody, and I wish you safe and happy holidays and everything. And thank you so much, Dr. Danzer. Oh, a question
Carolyn.
came in, I guess. Let's see. Oh, the question is, do you have counseling service on site for those after a failed IVF cycle? We work closely with our local therapy teams. I know some of the people Dr. Danzer works with closely, as well as I do, see people promptly if needed. We have some support groups through resolve.org. Any other comments, Dr. Danzer?
Yeah, there used to be a real popularity of of groups in the office, and unfortunately, the HIPAA requirements sort of eliminated that. Again, people talking about their private issues with other people. That sort of model has kind of passed us by, unfortunately. I think it was helpful. But again, that's again having the support group of the nurses, I think, on our program are very well equipped with being supportive of a negative pregnancy test. Again, I think the doctor is the first person to make contact about a positive or a negative test. In a way of, you know, get a plan to go forward, help to understand why it was negative, and that there are other steps, and that it can be hopeful about being successful with the next time. We know that for transferring embryos, there's been large studies now that really show that by the time people that have three couples or individuals that have three good quality embryos, the cumulative pregnancy rate is close to 90-some%. So initial pregnancy test can be negative, the first one, and the second one. By the time you get to the third transfer, the cumulative pregnancy rates are really quite high, 90-some%. But again, you have to deal with the negatives for the first and sometimes the second cycle. But you have to be hopeful that if you have good quality embryos, that successful pregnancy rates are very, very high.
Does anybody else have any questions? Thank you for joining us.
Have a great afternoon. Have a great holiday.
Take care.
Come back and see us again if you need to.
Okay, bye-bye.